Good morning, everybody. And I want to start in that way that just to be stylish is meaningless, and just to be simple and easy makes the meaning. I'm talking about safe radial intervention. And to see the coronaries and to treat the disease by PCI is our main goal as an interventionist. And the route, obviously, the vascular access is either transfemoral or the transradial approach. But to choose a vascular access over another, is it that much important, or is safety to be concerned? Here, the Plato's words I usually feel very much important that necessity is the mother of invention. And about TRA, what we can see that the guidelines trials, they usually say so. Lots of papers and guidelines and trials are there. And if you see all these landmark trials here, Rival Matrix, Rival HTMI, these are the trials. Safari HTMI has shown the benefits, the bleeding and vascular complications for the approach is lower than the transfemoral approach. And for ACS also, there is a dramatic improvement with the transradial approach, even in case of mortality also. And if you see the meta-analysis back in 2014 and in 2022, they have seen that the radial is better. So radial approach matters actually. Facts and fictions, what about a TRA so far? There are lots of merits, and obviously some potential demerits are also there, but the merits are more like improved patient comfort, lower rate of bleeding, lower rate of mortality, and there are some possible demerits like increased radiation, but it's not that much nowadays. But device restriction is there also. In fact, it is a gaining moment of that reason in the whole world, like in the USA and in our center also. If you see that back started in 2010, the real program, but in 2015, it has reached to the 99.5%, and now it's 99.8%. And in US also, it is incrementally because of its safety. And we know that the KISS principle for coronary intervention, the first S dedicates to safety. And here is safe, no doubt. And the question is how we can make it much safer, both for diagnostic purpose and the PCI, especially to prevent radial arteriospasm, perforations, overcoming anomalies like subclavian tortuosity, loops, arteriolocyoria, and radial arterial occlusions. These are the things. And perfection for TRA started from the very beginning, including the puncture and the sheet placement, meticulous use of the pharmacological agents, especially for the spasm-like agents, and appropriate catheter selections and also the changing the mindset for being radialist as much as possible. Hand vasculature, if we see that we are dealing actually with 6 sides, you have both left and right radial, both left and right ulnar, left and right distal radial also. So lots and options in hand to be a radialist here. So starting the flawless puncture, which is very, very much important in terms of a safe transradial approach, single or double wall puncture, anybody can choose that one actually by when flown or by bare metal needle. It doesn't matter actually which way you feel comfortable, but somebody says or some way it says that the double wall puncture is a little bit has got a more success rate. Right or left radial, the talent trial, which has inspired me at that time, and I did my own trial also back in 2013, but which shows that less fluoroscopy time and less contrast agent, but chance of PLIT is more, which I have now. So overcoming loops, about 1 to 2% the radial loops while doing the angiography. So we can overcome that on the back techniques or without back techniques. Sometimes tool can be managed by like using the guide wire, the coronary guide wires 014 or 025 with the hydrophilic guide wire, and which you can see here. Subclavian loops and tortuosity. If you see that these are the subclavian tortuosities and the roller coaster loops and the cobra loops, and all these loops are easily can be manageable. Sometimes a deep breath solves the issue in a very, very simple way. And so for CG, somewhere it is feasible, overcoming any sort of deformity and anomalies and rather comfortable for graft engagement. Still, for PCI, especially for complex one, gut feelings of number of interventions, it goes in favor of TFA for beta support for large bore like 7FGC. But is it possible to handle all PCI comfortably by TRA? That's a big question. Like say PCI by TRA, especially in these subsets which trembles the intervention world, like the high thrombus burden, the CTO evaporation, and heavy calcifications, and ultimately these things are called the cheap PCI, whether it's possible by TRA. Headaches while performing this TRA PCI is especially in this part of our planet where smaller radial artery diameter and especially the female populations have much smaller diameter and larger guide catheter more than 6 French can be overcome by sheetless guide catheter. Small radial artery diameter go for the ulnar or slender PCI like using the 5 French guide catheter. Inadequate guide support, increased active support can be done by alpha, gamma, and epsilon loops like these loops which I usually do and I'm very much comfortable with that one to make very good support. So now I want to show some cases where this sort of chip PCIs, where this pose become friends in transradial approach, like a complex left member application in a very elderly male patient with 84 years old. You can see that with the eye vessels also, and here the two-stand strategy, the decay crush technique was applied, and you can see that that the dais was blind and all the steps of decay crush was there. And the eye was pulled back, the final eye was pulled back was good, and final smile without any hiccup. This is a beautiful angiographic picture by TRA using a 6 French guide catheter. It is possible. If you go for the dealing with the severe calcification by TRA, I am talking about the severe calcifications. Like this case is a deep in this paradox, this pathetic picture with a 2 years back PCI with the stent in situ in the middle and pre and post segment is heavily calcified. How to deal with it by a TRA? Taking a 6 French, you can see here the picture, the graphic picture there. Even when we have taken a balloon, the dog body effects with 2.5 NC, you can see that one. And this dog body effects, even by the scoring balloon, it was really huge dog bodies there. And then we have to deal the IVUS, the nephrin ring calcifications that they are even, which has not been eliminated by the ballooning. So we can go for rota, but there is a standard segment there, so I'll be the last person to do the rota for this case. So I've chosen the IVL and for this case, you can see the IVL catheter 2.5 12 millimeter, and then stenting, and you can see the final picture here, which is really, really beautiful. And dealing with CTO and bifurcation by biradial approach, if the radial artery is very small, that is also possible with TRA. You see the angiogram here, and there you can see that there is a CTO LAD and also a severe complex bifurcation lesion in LCX and OM. So how we will approach this one is we have to handle the CTO and we have to handle a complex true bifurcation lesion which needed an upfront two-stand strategy for this case. But the patient's radiologist is so small that only can handle a 5 French catheter. We can accommodate that one. And so we have taken a 5 French gel for left, and obviously for CTO we need a dual injection, and that dual injection you can see that is beautiful. And then I have taken the special to wear, and you can see that there is a beautiful alpha loop here, and which make a very big, good active support to do the CTO, then the stenting and the LAD, and also the IVUS was done. Now the complex CVLNL with two-step strategy with decaminiculot, it is also has been done well by providing, and biradial access is there. Why not 2 French catheter we have taken here from the 2 radial axis, and you can see, but just only just meticulous vessel preparations and all the steps of decommunicator has been applied here. The only thing is that we don't have to engage the two catheters simultaneously in the left main. That is the most important issue here. And that's why the final picture, if you see, that is also very much comforting. So this is also possible here, especially in this part of the planet. What you can see here, smaller radiator diameter, especially in female, is a big concern here. And that's why, if you see this case also, it's a primary PCI where the patient was in cardiogenic shock and needed the IABP support because literally there is nothing left in the coronaries there. So what you have to plan for the PPCI to LD by 6 French guide catheter by radial approach for these patients. And after that, and you see the IBP support was still there. And after ballooning, you can see how a mega LED has come out and the patient has been recovered from there within 7 days. And also I can assure you that you have to make it slender. This is slender means if you see a 78 years old patient is sickly, present as TMI, obviously even spends further procedures for this patient is very much complicated one with a small radial diameter, multiple catheter manipulation is better to be avoided for these cases. So I've taken a 5 French gel guide catheter to see the left coronary artery first, and then the same 5 French guide catheter I've used to cannulate the RCA, which is easily possible by perfect manipulation. And then we have done the PCI in the RCA, and you can see the final picture is also beautiful here. And graft vessel intervention is also possible even by the right radial. You can go for it, or left radial is there for the graft vessel angiography. And in the graft intervention, like this graft, which is in a primary PCI setting, SVG with the highest thrombus burden is there to RCA, where the thrombosis suppression catheter was taken. Then we have done the stenting there. And after that, you can see that the pristine clear picture of the SVG towards CA. So this is, so to wrap up, we can tell here that TRA is a beauty and passion, both for patient comfort and safe intervention, possible or feasible in cheap PCI also. Of course, need a good and stable learning curve. And finally, a steady mindset for the operator to be a good, strong radiologist. Thanks for patience hearing, and thank you very much for inviting me here.